There you go.
There we go. All right. Well, I'm really very, very excited that Dr. Baer has joined us this morning to talk about something very important. It's, I know, important to all the folks who've joined, including me, because Dr. Baer, I'm going to tell you about all of his accolades and everything, but
Don't spend too much time on that.
I think the main thing, though, and I'm going to take a moment for this, is he was my breast cancer surgeon. So that's probably the shining thing he did in his career. He's been at VCU for 38 years, treating lots of people. Here are his titles. He's a professor in the Division of Surgical Oncology. He's a professor of surgery, microbiology, and immunology. And he's the interim associate director for clinical research at VCU Massey Cancer Center. His clinical interests include not only breast cancer and other breast diseases, but also melanoma, sarcoma, and gastrointestinal cancers. He's a prolific author, having authored more than 190 articles and book chapters, published in several prestigious medical journals. Today, he's going to talk to us about breast cancer, and specifically triple negative breast cancer and some breast cancer research going on at Massey Cancer Center. So with that, I'll turn it over to Dr. Baer.
Thank you, Amy. So I'm going to focus on triple negative breast cancer, but it won't be the only topic. So let me just there we go. So I'm going to talk about a little bit about neoadjuvant systemic therapy. That's an area that I've worked on a lot. I'm not going to cover the whole waterfront on that. I'm going to talk a little bit about antibody drug conjugates, which are really sort of the new players in the field. And I think they're going to make major inroads, not only breast cancer, but other cancers as well. I'm going to talk a little about the clinical impact of immune therapy, which is an area that I've worked on for most of that 38 years. And most of that 38 years, a lot of people sort of poo-pooed it as being irrelevant. Now it's the hottest thing since sliced bread, and the word immuno-oncology is everywhere. That word didn't exist. And then I'm going to talk a little bit about the recent and ongoing trials at Massey for triple negative and others. So way back in mid-1980s, we did this study as a national study with the National Surgical Adjuvant Breast Project, and really was my start at doing clinical trials. It was a pretty simple question, and that was, should we give chemotherapy before we do the surgery, or should we keep doing it the old way where we give it after the surgery? And there were a lot of theoretical reasons why some people thought it would be advantageous to give it before the surgery. And there are some advantages, but we learned a number of things from this trial. First of all, and I don't know whether you focus pointer, I'm going to make it. So we learned, first thing we learned was it wasn't better to give it pre-op in terms of patient survival. But it was exactly the same in terms of survival. But that allowed us to convert more than a quarter of the patients who wouldn't have been able to save their breast, would have required a total mastectomy, could be converted to breast conserving surgery with no cost in terms of survival. And the third thing we learned, and this is really important, has become more and more important as we go along, is that patients who have what we call a pathologic complete response, that is, no invasive cancer in the breast or the lymph nodes when we do the surgery, they do extremely well, much better than even patients who have a good clinical response but still have microscopic disease in their breast. Those are really three important things we learned. And this has been, this importance of pathologic response has been borne out in multiple other studies. This is a big meta-analysis. That means they've taken the data from many studies similar to the one I just showed you and compared pathologic complete response patients' survival to patients who did not have a pathologic complete response. So the hazard ratio is almost a third, which is huge. So this is over 11,000 patients.
What is a
So
pathological response? What does that
a
mean?
pathologic response means when the surgical specimen is removed, there's no invasive cancer in it at all.
Okay.
It does allow for a little bit of duct carcinoma in situ, which is non-invasive. We wouldn't expect that to be sensitive to chemotherapy. But pathologic complete response is sort of the holy grail of preoperative treatment. So it's a very strong predictive marker. For a while, the FDA was allowing approval of at least an accelerated or preliminary approval of drugs based on pathologic complete response. Turns out on a trial level, it may not be good enough to approve drugs until you can confirm it in a bigger trial. But clearly, it's a predictor of a good outcome. On the other side, I'll show you, it's not having a path CR is a predictor of a very bad outcome. These patients, by 200 months, which I guess is what, 8 years, 9, 8. So 10 years would be here. By 10 years, 40% of the patients have died.
Mm-hmm.
In that group. So, but when we discovered this, nobody knew what to do about it. In other words, does adding more treatment help pull this curve back up to the other group? And I'll show you how that's been accomplished. So that's the big question. Could the response impact the treatment after surgery? And so for triple negative breast cancers, the first study that showed we could do something about it was this study from Japan, where they added an oral drug, Capecitabine, which is similar to 5-fluorouracil, but it comes as a pill. And these were for patients who had triple negative breast cancer who did not have a pathologic complete response. And you can see the patients who didn't receive any more treatment, just like in the curve I showed you a moment ago, did badly. But when they got this drug, this oral chemotherapy pill, it improved their outcomes significantly. Not 100%, but certainly much better. And this is another trial. This is a trial for patients with BRCA mutations, including some patients with non-pathologic response. In other words, that makes them high risk. And it helped to show that a PARP inhibitor, which is a specific type of drug, it's also an oral agent. It poisons part of the pathway to repair DNA damage, which is already a defect that these mutation-associated cancers have. So about half the patients in this trial were non-PCR patients. So again, it improved the disease-free survival from 77% at 3 years to 86% at 3 years. So, I mean, that's very significant. That was published last year. The same is true. What about HER2 amplified or overexpressing patients? And so this is where one of the first antibody drug conjugates came along, and I'm going to explain how these work because it's really cool. And actually, I had slides talking about antibody drug conjugates when my slides were 2x2 transparencies that I put in a carousel. So that the idea has been around for a long time, but it really hasn't gotten to the clinic until fairly recent. And so this is trastuzumab, the purple thing here. This is the antibody against HER2 that we now use routinely. And these little spiky things are a chemotherapy drug called Imtansine. Imtansine works by inhibiting microtubule. That's not so important. But what happens, the key is these little lines here. These are the linkers. This is what hooks chemotherapy drug with the antibody molecule. So when the antibody molecule binds to HER2 on the cell surface, it goes inside the cell and it gets incorporated into what's called a lysosome, which has enzymes in it that cut this linker. And then that releases the chemotherapy drug that then kills the cell. kills the cancer cell. And emtansine was actually tried as a chemotherapy drug by itself, but it was too toxic. It couldn't be used. You can't give this drug to patients intravenous. But by hooking it to a targeting molecule or a guided missile, if you will, it only goes to the cancer cells and not to other cells. So this is a principle. This is gonna be a repeating theme here, and it's also applicable to triple negative breast cancer. So what? So we took this same idea. So this is for patients. Catherine trial. These were patients who had HER2 overexpressing breast cancer and had residual disease. In other words, they did not have a pathologic complete response. And they were randomized to either the standard of care, a standard of care, which was to continue to receive anti-HER2 antibody, or the same antibody, but with this emtansine hooked onto it, this antibody drug conjugate. And when the results, so again, switching to this other drug, the antibody drug conjugate, dramatically improved patient outcomes compared to the standard of care. So this is now being tested in earlier stages of disease, perhaps even as primary therapy, and much less toxicity. It was actually in metastatic disease, it was actually compared to chemotherapy, and it was superior to chemotherapy, and obviously a lot less toxic patients. So what about for triple negative breast cancer? For triple negative breast cancer, this is another antibody drug conjugate, antibody to TROP2, which is on the surface of a lot of cancer cells, and it has a different chemotherapy payload, it's called, and it's got a lot of these little molecules on it, which this one is similar to some other chemotherapy drugs. It's related to irinotecan, which doesn't really matter, but again, the idea is the same. The antibody hooks on to the TROP2, and then it goes inside the cell, and then the little linkers get cleaved or cut, and then the chemotherapy drug kills the cells. They can't multiply and divide anymore. And so in the metastatic setting, so this is in metastatic triple negative breast cancer, comparing this antibody drug conjugate to chemotherapy. And again, this is overall survival, which in patients with, these are patients with metastatic disease that have already failed 1 or 2 lines of chemotherapy. So they really are in trouble. And this antibody was better than chemotherapy of the physician's. So again, another antibody drug conjugate that's really coming on the scene. I can't remember when this was published, I think 2020. And here's another one. This is trastuzumab. Again, it's an anti-HER2 antibody, and it's the payload is called deruxtecan, and deruxtecan damages DNA and kills the cells. And what's interesting about this drug, so we know it's very effective for patients with HER2 overexpressing tumors, but it also works even if they don't overexpress HER2. So a lot of triple negative breast cancers and hormone receptor positive breast cancers may not be HER2 positive by the standard criteria, but they can have HER2 expressed at low levels, 1+ or 2+, but are considered negative. And again, comparing this drug, which is called Enhertu, it compared to chemotherapy of physician's choice. Again, a major improvement in what we call progression-free survival. That is how long a patient goes before their tumor starts to grow again. About 10% of these patients would be called triple negative. And you can see this is the trastuzumab deruxtecan group, and this is the chemotherapy group. So again, almost double the time that what the patients went before progression. Again, these were patients who already received standard of care therapy, at least 1 or 2 lines of standard therapy.
And did you say all these therapies that you've been talking about are less toxic than sort of what we think of as traditional chemotherapy?
Yes, because all of them use the antibody to target the chemotherapy drug to the cancer cell. And the rest of the patients getting only minimal, if any, exposure. So that's the beauty of antibody drug conjugate. It's what some of the early investigators back in the 1940s call the magic bullet. This really fits that description. We haven't had a magic bullet. So this idea of HER2 low targeting is about to be tested in early breast cancer. The protocol is still being developed. Any other questions? That's sort of it for antibody drug conjugates. Okay, well, I'll move on to the topic that's near and dear to my heart, and that's oncoimmunology, or the cancer immunity cycle. And this is what we think happens in cancer. So when a cancer cell dies, it releases antigens, little dots here, and they're picked up by antigen-presenting cells. They're monocytic cells that normally work to present like viral antigens or bacterial antigens or whatever. Pick them up and they take them to a lymph node where they interact with T cells or cytotoxic T lymphocytes, and they get activated there. And then they leave the lymph node and go into the bloodstream, and they circulate around to the tumor blood vessels, and they come out, and then they recognize the same antigen on the tumor cells, and they kill them. And then the whole cycle goes on again, because when these cells die, they release antigen, and it goes around and around. So this was the idea. Everybody thought this was hooey for about the last 4 decades, previous 3 decades, until the last 5 or 10 years. So we've known for a long time that the number of lymphocytes, those white blood cells that I was talking about, in the tumor, in breast cancers in particular, are quite variable. They go all the way from 0, no lymphocytes, to 80% lymphocytes. In 80% of the area of this tumor slide is composed of lymphocytes. And the highest number of what we call lymphocyte predominant breast cancer. There's more lymphocytes than there are cancer cells. And when people looked at this as a prognostic factor, they showed that patients with the highest grade of tumor infiltrating lymphocytes, on the brown line here, I guess it might have been red originally, but this brown line, they do the best in terms of overall survival. And the fewer lymphocytes that are found, the worse they do. So this was a clue that maybe this was important. Maybe the immune response in the cancer is important. And so when and not only does it affect prognosis, it affects, again, here's that pathologic complete response rate. This was in a large clinical trial. And the overall pathologic complete response rate in the trial was only about 13%. But if you just look at the lymphocyte predominant breast cancers, or the breast cancers that had even 10% lymphocytes, which is low but clearly positive, it was much higher, 31%, and here 42%. So again, an indication that not only are lymphocytic infiltrates prognostic marker, they're also a predictive marker. They predict that the tumor is going to respond well for therapy. So how can we make the immune response work better? And this is the the, the checkpoint blockade. What are checkpoints? So checkpoint blockade is what two scientists, one in Japan and Jim Allison and MD Anderson, won the Nobel Prize for a couple of years, 2 or 3 years ago. They discovered that this molecule on the T cells and this molecule on the T cells, if they bind to their ligands, it shuts them down. It blocks their ability to either be stimulated or to kill a cancer cell. And so what those two investigators did, they made antibodies to these two proteins. And they showed that when you use these, when you treat a tumor-bearing animal with these antibodies, the tumors just, or they grow much more slowly. So just one example in patients with metastatic triple-negative breast cancer, where one of these antibodies, pembrolizumab, which you've probably seen advertised on TV, it's called Keytruda, is actually standard now for lung cancer and melanoma, but it's taken a longer time for it to find a place in breast cancer. So in patients, these are patients who had already received standard of care chemotherapy and failed, and they were randomized to chemotherapy or chemotherapy plus pembrolizumab, which is an antibody. And again, you can see it almost doubles the percent of patients, percent of patients who don't progress. The disease shrinks and doesn't grow back for a period of time. Now, doesn't cure everybody. Patients are already failed a lot of therapies, but the idea of using this in the preoperative setting, in other words, when I talked about at the very beginning, the neoadjuvant setting, before the patient have surgery, is really important. And the reason it's important, and I'll show you another slide of this in a minute, but again, this is this cancer immunity cycle where the tumor is here, and there's some lymphocytes in there's T cells and these antigen-presenting cells in the tumor, and they carry the tumor antigen back to the lymph node, and then the T cells leave the lymph node and get into the bloodstream, and they can go either to the primary site, or they can go to metastatic sites in the lungs or the bones or the brain, and attack little tiny deposits of cancer that we can't even see. And so the advantage of doing it in the preoperative setting is this: if you wait till after the patient's already had their surgery, well, most of the tumor antigens are gone. There's nothing for the immune response to see. So if you give the antibodies, there's not any antigen, and there's nothing for them to see. Whereas if you do it before surgery, then wait a little while, then you have all these tumor cells that the lymphocytes can respond to, and lots of different lymphocytes, different clones, as we say. Then you go ahead and take the tumor out, and now all these cells are still in the patient and can attack other sites of disease. So that was tested in a number of trials. This is what's called the Keynote 522 trial. It's again taking advantage. It's all triple-negative breast cancers, and all the patients got exactly the same chemotherapy, which is standard of care: carboplatin, paclitaxel, idrimycin, and cyclophosphamide. And half the patients got a placebo, and half the patients got the pembrolizumab, immune checkpoint blockade that reacts with PD-1, which is one of the checkpoints that's used. So, and then they had surgery. Patients in the pembro group continued their pembro for another half a year. What happened? Well, the primary endpoint was, again, this pathologic complete response rate. Initially, it was almost a 14% improvement in the pathologic complete response rate. Now, instead of 12 or 13% path CR, we're talking about 65% pathologic complete response. but that again, so the FDA had stopped giving accelerated approvals based just on CAT-CR. But when they looked at event-free survival, that is, patients went for 3 years without any kind of recurrence, either locally or systemically, it improved by about 8%, 77% to 85%. So this has now become standard of care in the neoadjuvant setting. And in fact, most triple negative breast cancers, unless they're very small, this is the therapy they're going to get routinely. And that's based on this trial that was just published this year. And it's already, I think it was July of this year it was published, and it's now standard of care. And in the lab, we've been trying to figure out how to make the immune therapy work better. So we give a little dose of chemotherapy, we give the immune checkpoint blockade, and then we give what's called a DNA methyltransferase inhibitor. And I'll tell you what that does in a minute. And we start the therapy about a week after the cancer cells have been into the mouse. And when we do that, you can see this is the control group here. This is their tumor size in volume. When we combine the checkpoint blockade and 1 dose of chemotherapy, not 6 cycles of chemotherapy, just 1 dose, and this DNA methyltransferase inhibitor, 4 out of 5 mice were completely cured. Their tumors never really got very big. Their tumors eventually went away. And this is their survival. So this is survival curve, just like I showed you in the clinical trials. So this is a group of mice that got immune checkpoint blockade plus another DNA methyltransferase inhibitor, had the best survival of any of these groups. So what does the DNA methyltransferase inhibitor do? So one of the things that cancer cells do in order to escape immune responses or to become malignant is they shut certain genes off. And they do that by attaching methyl groups to and so to stop that or reverse it, what we found is that they increases tumor antigens, they stimulate a stronger T-cell response, and maybe most importantly, they inhibit myeloid-derived suppressor cells, which are one of the things that happens in patients and mice when they get progressive tumor growth. They have these myeloid cells or cells from the bone marrow that actually shut down the immune response, inhibit the immune response. And so we showed that you could improve the efficacy of immunotherapy by treating the mice with these DNA methyltransferase inhibitors. And so we decided to do a clinical trial where we took a needle biopsy and we gave this DNA methyltransferase inhibitor with, just before giving 2 doses of the pembrolizumab immune checkpoint blockade. Then we did another biopsy before they started chemotherapy. The main target of this was the triple negative breast cancers, but we did include some patients with hormone receptor positive tumors that were high grade and benefit from chemo. But they didn't get they started the chemotherapy after the immune therapy was started, and then they got surgery out here. The main thing we want to see was, does this treatment increase tumor infiltration? So we enrolled 47 patients on this trial. It's actually completed enrollment. We're just waiting to make sure that everybody gets this second biopsy because that's the main endpoint. Once we get to that point, which will be probably in the next few weeks, we'll be able to analyze the data. We'll close the trial. Now, partway through the trial, we had to add pembro to the chemotherapy the way they did in KEYNOTE-522. Couldn't really deny patients getting standard of care treatment in addition to pembro. That trial, we did this trial with collaboration from University of Virginia, Ohio State University, and medical oncology group in. So so this is just the list of all the trials that are getting going for new concepts and trials. Remember I mentioned the Ruxtecan. So this is another trial that's going to be done for HER2 negative breast cancers with hormone positive disease. I mentioned this antibody drug conjugate that we already know works for negative breast cancer, is going to be tested for patients with brain metastases. That trial is open. Then we have the T-DM1, which is another antibody drug conjugate I talked about, plus tucatinib, which is a small molecule inhibitor of HER2 signaling. We have a very interesting trial for women who have low risk breast cancers, admit radiation therapy if they have low current score and are over the age of 50. There's a trial going on where we're comparing two different antibody drug conjugates in high-risk patients with HER2 positive breast cancer. Again, those who have not had a past CR with their neoadjuvant therapy. This is a trial for hormone receptor positive breast cancer, looking at oral SERD, which is a selective estrogen receptor degrader. We know that this drug is better than our current standard anti-estrogen therapies in the metastatic setting, and we're going to compare it. We'll be comparing it to standard of care in the adjuvant setting. Those are patients who've undergone curative surgery and adjuvant therapy. Dr. Arthur has this trial, which is close to being finished, where they give the regional nodal radiation in patients who need it in a much more accelerated fashion to try and cut down on the time spent in getting radiation. Again, we're looking forward to trying other ways to increase the immune therapies, and there's a lot of interest now in de-escalating therapy in patients who have good responses, chemotherapy with or without immune checkpoint block. Another really exciting area that we talked about at a cooperative group meeting a half ago is using circulating tumor DNA, or what people call ctDNA, to be able to predict or detect residual or recurrent disease early. It's already been shown to be extremely powerful prognosticator for cancer. So we're going to try to do the same things in breast cancer. So the patient has all their treatment, and you take a blood sample, and they've still got abnormal DNA in their blood. Does that mean that they actually have metastatic disease that we just can't see? And should they get more treatment? On the other hand, in patients who are doing great, and you check a blood sample every 3 to 6 months, and all of a sudden the circulating tumor DNA pops up, that probably means that they're going to have a recurrence soon, and maybe we should treat it early. The serum markers we've used in the past haven't really panned out as beneficial to patients. Serum markers like CA-19-9 and CA people sometimes get routinely, but they haven't really panned out. But the circulating tumor DNA is looking for the same mutations that are present in the cancer in the bloodstream.
Can that be used for any cancer patient, breast cancer?
Yeah. So, well, we don't know yet. So there's two different ways to do this. One is to just take a blood sample and look for abnormal pieces of DNA, or pieces of DNA with abnormal sequences or abnormal base pairs. the other way that's probably going to work better is to have a sample of the patient's tumor, so you know exactly what abnormal pieces you're looking for, rather than sort of a shot.
Okay.
So the two different ways to do this, and which one's going to be best for which diseases is still hasn't been determined. Both there's several commercial companies that have these tests available.
So do you predict that one day that will be done for all breast cancer patients after they finish their therapy?
Possibly, yeah. We still have to do the research to find out whether it makes any difference. I mean, when people looked at whether serum markers, you know, the protein markers, glycoprotein markers in the blood could help increase cure rates for breast cancer, it didn't work. And the reason it doesn't work is, yeah, they do pop up a little sooner than you would find the recurrence clinically. But it doesn't make that much difference in terms of treatment. It doesn't make any difference in terms of survival. So if you start treatment 3 to 6 months earlier, it doesn't cure more patients. So probably the most powerful way to use this would be right after you finish treatment. If there's still circulating tumor DNA in the blood when the treatment has been finished, that probably means that some of the tumor didn't get killed, and it's somewhere. But we have to have something else to add. That's the problem. But now we're starting to have things, particularly so in patients with residual disease who don't have a pathological complete response. We can shift the treatment and improve outcomes.
Okay.
So we didn't have that before.
So maybe instead of being used ongoing, it might just be like have you really graduated or not?
Right. Are you a stage 3 patient or stage 2 patient whose tumor is gone, or are you really a stage 4 patient? We just didn't know it yet.
Right. Okay.
So, and then finally, I think this is a very interesting one. We know that patients who have low to intermediate recurrence score, that's the genomic profile that we use in hormone receptor positive breast cancer. We know from a recent trial that chemotherapy didn't add anything to patients who are postmenopausal. It did seem to help patients who are premenopausal. But the question that we haven't answered yet, did the chemotherapy kill more cancer cells in those patients, or did it just shut their ovaries down, make them menopausal? So the trial is about to get started in premenopausal women to determine whether or not if they get their ovaries shut down with a shot every month, then maybe they don't need chemotherapy. So they'll get endocrine therapy and ovarian suppression, and half will get chemotherapy and half won't. And so it would be nice if a lot of those premenopausal women have their ovaries temporarily shut down and not have to get chemotherapy. But we need an answer to that question. I think that's a very interesting one. So, and then just one more thing. This is something that Joe Landry has been working on, and I'm collaborating with him on this. So he's looking at epigenetic changes that occur when cancer cells are treated with chemotherapy, and sort of the tumors go away or seem to go away, but then they come back. And there are a lot of different reasons why they go into this resting state or senescent state, or where they're not dividing and not growing. And this period of time may be a few months or 20 years. And so he's looked at factors that may be required for this recovery, and we're going to test once we figure out which genes, epigenetic changes, are responsible for this recovery. then we will be able to give drug here when they're and keep them starting to grow again. So he and his graduate student have done a lot of work on this in tissue culture, and then we're later going to look in what's called T-DxD mouse models. That's patient-derived xenografts. Those are tumors that have been taken from pieces of cancer that have been moved at surgery and implanted into mice, grow, and we're going to try and figure out whether these drugs will prolong or eliminate recovery of the cancer cells from chemotherapy treatment. So that's all I got.
I have a question, Dr. Berry. You mentioned that immunotherapy for many years, I think you said, a lot of people said, that's never going to work for this.
Right.
What was the reason for the skepticism, and how did you break through that skepticism?
Right. Well, so we had shown that you could use tumor-infiltrating lymphocytes or lymph node lymphocytes and grow them up in culture and give them to the patient, give them to mice, and cure and cause your cancers to go away. The initial, there was just a lot of skepticism, and the major successes for immunotherapy, number one, involve very complex procedures, sort of like CAR T cells, where you grow T cells in culture and then give them back to patients. They're very so they're very cumbersome, to say the least. And the tumors that they work the best in were melanomas. And melanomas are funny. Melanomas have a lot of abnormal antigens. The reason they have a lot of abnormal antigens is they're caused by UV irradiation. And UV irradiation damages DNA and causes a lot of mutations. Common, what we call epithelial cancers or carcinomas, don't have so many mutations. So they don't have as many targets for the immune system to respond to. But the discovery of immune checkpoints and then using immune checkpoint antibody, immune checkpoint blockade is how it's called, that eventually led to those two investigators winning the Nobel Prize, really put immune therapy into treat for everyone. Because you could take a bottle off the shelf and give it to the patient. You didn't have to make something new. And initially, it worked great for melanoma. Then it worked great for lung cancer. Lung cancer, sort of like melanoma, has a lot of mutations. Why does it have a lot of mutations? Because it's caused by cigarette smoke. And stuff in cigarette smoke causes mutations, and mutations lead to a lot of abnormal proteins which become tumor antigens. So lung cancer and melanoma, and then the other group of patients that respond extremely well to immune checkpoint blockade are patients with what's called Lynch syndrome, which is a DNA damage repair deficiency. So patients with Lynch syndrome have an inherited abnormality which limits the ability of their cells to fix DNA damage. And so they accumulate a lot of mutations. And a lot of mutations lead to a lot of neoantigens or tumor antigens that the immune response can respond to foreign. But that's a unique and pretty rare group of patients. In fact, the Lynch syndrome, or patients with DNA damage repair deficiency, was the first group of patients ever to have a treatment approved regardless of what tumor type they have. So in a patient who has that genetic defect, doesn't matter whether they have colon cancer, rectal cancer, uterine cancer, or any of the other cancers that are common in Lynch syndrome, they respond well to immune checkpoint blockade because all their cancers have a lot of neoantigens. So that, and honestly, not all patients respond to immune checkpoint blockade or immune therapies, even in the diseases where it works the best. So there's a lot of work going on, try to make it work better. Try to overcome the obstacles therapy work. I don't know if that answers your question. But
Do other people have questions for Dr. Bear? Don't be shy if you've got
yeah,
it.
glad to take on Amy and me hung the show. If not, thank you for your time and attention, and I'll give you 11 or 12 minutes back. Okay.
This has been really great. So thank you very much, Dr. Bear, for coming. And I just want to say thank you to those who joined to hear lots of great information about what's happening in cancer research for really tough cancers, and lots of great stuff happening at VCU Massey Cancer Center. So thank you.
All right. Thanks. Have a good afternoon.
Thank you.
Thank you, Dr. Bear.